Substance abuse and addicted disorders. Substance abuse disorders that can lead to some pathological issues as well. Um, these clients will have, they may have risky behaviors. They may use them riskily, these substances. They have impaired control, social impairment. It could affect them physically. They could go through intoxicate. They could develop intoxication, get intoxicated rather. They can build up a tolerance, and also, if so, once they become intoxicated and a bit of a tolerance, some physical effects, and they may go through the withdrawal process, which is very critical. It's a medical emergency. These are some substances here that can lead to disorders. Again, I'm not going to name all of them, but most of these you're familiar with, I'm sure. And going back to the basics here, these substances can lead to physiological and mental problems as well. Some other addiction, as it relates to substance abuse, could lead to gambling, shopping, sex, again. And we see a lot of our young population using inhalants, things like glue, um, to um, to become intoxicated. Caffeine, of course. And again, like I said earlier, addiction can lead to medical problems. Um, when a client become intoxicated, of course, they have an excess amount of the substance that they are using. Intolerance, for instance, if someone is addicted to opioids, for an example, it takes more and more opioid to get them to that initial level of response. Meaning that if once a person, I was told that once they start using marijuana or cocaine, that first time they use it, they get to that very, very high level. And so what makes them addicted is that once they continue to use it, they're trying to use it to get back to the highest level, that high level that they were at the beginning. And they never get to that point. So therefore they become addicted because they're repeatedly using that those drugs or substance to get to that initial level of high. Then, of course, we all know withdrawal, when a person tried to stop using the substances. And I've witnessed some clients coming into the hospital that were going through withdrawals. May have came in for surgery, but they were addicted to alcohol. And so they went through the withdrawal process. And so they became critically ill, but had to be placed in an intensive care unit, not because of the surgery, but because of they were going through withdrawal due to the absences of that alcohol. This is a case study. A 20-year-old was found badly beaten, semi-comatose in the alley. He passed out and vomited and was brought to the police, brought by the to the ER by the police or ED with an alcohol level of 0.15. Now, in your book, it breaks down what the different the blood alcohol level. You may see the term BACA, and that's basically when a client is determined intoxicated, it's based on that level, the blood alcohol level. And we're going to talk about that a little bit. It's on page 419. So with that being said, with the I think the alcohol level here was 15, I believe, percent. So if you go to that page, it'll tell you what 15% means. So with this being said here, um, this means that this client had 8 to 10 alcohol drinks. They usually have a blackout spell, and they vomit, and they become nauseated. So again, we look at that alcohol level. So he looked around the ER environment and panicked and struggled to get up. When the staff calmed him down, he struggled not to cry and said, "Why didn't you just leave me there? Why didn't you just leave me there, leave me to die?" So apparently this client is suicidal. We don't know if he drunk that much of alcohol to commit suicide, but apparently based on the scenario or the case study, apparently that he was suicidal. Again, as we look at the clinical picture for caffeine, this is mostly widely used substance in the world, and it can lead to intoxication, overdose, and withdrawal as well. Cannabis, it's the third most common used psychoactive drug in the United States after alcohol and illicit drugs. Hallucinogen, hallucinogen substances can have a profound effect on a client's in their disturbance in their reality. And so if there's a disturbance in reality, it's going to put them at risk for injury, self-harm, and things of that sort. Okay. And again, with the halogens, these clients also go through withdrawals. Um, when we talk about halogens, these are usually your Schedule 1 controlled substances, meaning that they have no medical use and they carry a high abuse potential. Um, Halogens can be found in plants, mushrooms, or their abstracts. I'm sorry, extracts. Okay. Inhalants, again, these are solvents, like I mentioned earlier, glue, adhesive, propellants, like paint thinners, whiteout, black whiteout, the little stuff we used to buy in the bottle, fuel, of course, opioid disorders, heroin, and other prescription drugs. With again, like I said, with when a client is addicted to or become intoxicated or addicted to opioids, they crave for large amounts, because they try they once they started at a low dose, then that tolerance is going to increase, so they want more and more to get them up to that, they tolerated and now they need more to get them up to that high. So again, with that being said, they have a significant impairment in life in their role, jobs, um, interpersonal relationship. Then again, they become physically hazardous. Again, if somebody is intoxicated, driving, using machineries and things like that, they're going to be at risk for injury. So again, we want to make certain that's just when clients you give them medication and controlled substances or something for pain or whatever the case. But before they go home or discharged from the hospital, they can't leave within a certain time frame, and then they need someone to drive them home because they're going to be at risk for injury. Then working on the jobs, operating heavy machineries or machines, things of that sort of put them at risk for injury. Um, as far as the overdose, these with opioid intoxication, these clients usually die from respiratory issues. They go into respiratory arrest. So again, naloxone, Narcan is the drug of choice for opioid overdose, and they are using it in the schools. Also, some other drugs or other treatments for these clients with opioid withdrawal, methadone. There are a lot of methadone clinics out there, clonidine, uh, norepinephrine, and also naloxone, another one. Lexaphodine is another withdrawal medication that could be used. Uh, um, and then again, some maintenance. We try to get these clients that once they go through, um, maybe they're going through the methadone clinic, then we have to put them on a maintenance plan so that to keep them from, relapsing. So again, it's very important that they are on a maintenance plan. Now, sometimes clients come out of treatment, they don't they'll come out, they'll go into the maintenance phase or recovery phase, I'm sorry, then they'll regress back. So again, it's kind of difficult sometimes to keep the clients in the recovery phase, particularly if uninsured, they may not have transportation, may not have support system to get to the clinics or get their medication to maintain. Then you have some other problematic substances, and medications that are problematic. Your benzodiazepines. There are also some benzodiazepine lookalike drugs, alike drugs, I'm sorry. Carbamates, barbiturates are also some problematic substances. And then barbiturate like hypnotics. How do we eradicate, how do we remove these substances from the body if a client is overdose? There are a procedure called gastric lavage. We used to do it a lot. In the emergency room, we put that big gastric tube down, the barge tube, and we use activated charcoal. And at that time when we did it. These clients were not sedated because if they're already overdose, and you give them something to further sedate them to get the tube down, you could further compromise their respiratory system. So again, we just put that tube down. We had frequent flyers to come in overdose, and we had to put the tube down to remove the substances from the body. So we withdrawals, again, these clients go through withdrawals. We don't try to get them in withdrawal instantaneously. It's a gradual reduction process because if you get them, you try to, take them through the withdrawal phase too quick, they can develop seizures. So again, it's a process that you go through the withdrawal process. Um, as far as stimulants, there are some stimulants, like I said, that have different effects as well. I don't know if you have heard amphetamines. This was a drug that was used years ago that people use for weight loss, but it's similar to, you get that same effect, that stimulus effect. So what happens here, it increases the respiratory rate, whereas your opioid decreases the respiratory rate. So these stimulus stimulates, okay? And the second only to cannabis is the most widely used one, those amphetamines, cocaine. Um, as far as treatment for these clients, they benefit really well if we can get them in group therapy and also individual therapy. Sometimes they get very agitated. Diazepam, we can use that for agitation. It takes about 1 to 2 weeks to go through cocaine withdrawal. Sometimes it requires no inpatient care, and there are no drugs that are used to reduce the symptoms. However, like I said, none to reduce the symptom, but if they get agitated, they can use some diazepam for the agitation. Then, as they go through the withdrawal phase, these clients also they may become depressed. So this is where you want to use some buspirone for the depression, because they're gonna become depressed, coming down. All of a sudden a client is very hyperactive, they're stimulated. Then you go through the withdrawal phase, they're gonna become they have problem sleeping at night. Then again, they also are risky. They're at risk for injury. Okay. Another disorder, tobacco. We know the effects of tobacco, how what effects it has on the body. Um, Going through withdrawal with tobacco is also depressing. Gambling, there are Gamblers Anonymous support groups out there, and these are some possible treatments for gamblers. Buspirone, SSRIs, mood stabilizers, and anticonvulsant. Okay. Sometimes, when you may have seen clients in the hospital with nicotine patches on. These are some treatment initiatives that will help these clients go through the withdrawal period. Some clients uses hypnosis. Okay, so again, it just depends. Varenicline is a drug that's used in buspirone. Also, it's a drug that can be used to help these clients go through the withdrawal of tobacco. We get them in the recovery phase again, and sometimes they'll come in, they'll stay, and then they'll go back again. So we're going to review these audience questions tomorrow, I'll get you an opportunity to provide feedback. Alcohol disorders. Again, this is a sedative also. It has a sedative effect. Again, usually these guys, when they go through different symptoms, they could be severe. And to diagnose these clients, again, they use that DSM-5 manual. And with mild symptoms, they may present with 2 to 3 symptoms. Moderate, they may present with 4 to 5 symptoms. So we assess these clients, and then we determine how much you drink, how many per day, um, what do you drink? Again, so this to determine what symptoms are exhibiting. Um, and we know the effects of alcohol on pregnant women, on the baby. Again, this severe, they have 5 or more symptoms. There's an extensive list of the DSM-5 in your book, of the criteria for alcohol abuse. And again, like I said, it's over a period of time. We look at these clients, not just 2, 3 months, it's over a period of time. A problematic pattern of alcohol use is leading to physical, clinical judgment impairment or distress. Again, they have to manifest at least 2 of the following symptoms over a 12-month period. And I'm reading this little box in your chart on page 417. And ask about they crave for alcohol. They Usually, sometimes they crave, um, and they crave to the point they may drink at work. They may come to work drunk, I'm sorry, or intoxicated. I'll put it that way. So again, there's some criteria that's being used to help to determine which, how what the symptoms are, uh, how the symptoms impact these clients as well. Some clients they may call themselves they can work, they drink, they can drink and work at the same time. Again, so it just depends based on this criteria that we use to assess these clients with. Like I said, it's an extensive list in that box. But it starts on page 417, goes over to 418. And as far as epidemiology, you see it's more prevalent in men than women for the most part. And as far as race and ethnicity, you see a high population in the highest population in your American adult Indians in Alaska, Native. Just not really significant. Just want to share that with you. These clients that have alcohol abuse or use, they usually have other comorbidities, other issues, they bipolar, schizophrenia, antisocial disorders, and then major depressive disorders. So again, they drink alcohol as a method of coping. Again, alcohol could be genetically linked. There could be some neurobiological issues going on, again, in the brain. Again, this will show on a functional MRI as well. They look at the client's memory response when they're looking at the scan, the MRI. So again, that's basically one of the tests they can use to determine whether that alcohol has impaired a client's mental status. Environmental, again, going back to that, their home. It could be cultural, uh, tired, linked rather. Okay. So like I said, again, um, as we look at again, alcohol becomes problematic when it completely impairs a client to the point where they start driving under the influence, or they become, aggressive behaviors. Again, they become risk takers and things like that. So it's really significant, a significant issue at that point. Binge drinking, you may see some to hear the term binge drinking. Refers to drinking too much alcohol quickly. They just drink it, just like we talk about binge eating. There's binge drinking also. They drink it really quick. Um, and then also heavy drinking, drinking too much alcohol too often. This is where clients may drink 8 or more drinks in a week, uh, contributing to heavy drinking habits. You see, there's going back to that intoxication chart on page 419. As you can see, the legal definition of intoxication in most states, the blood alcohol level, you may see this again as BACA acronym, is anywhere from 80 to 100 milligrams of ethanol per deciliter of blood. So again, often it is expressed as 0.08 to 0.10 um, grams per deciliter. So that's how it's usually um, expressed, or you may see it written that way. And then, like I said again, withdrawal. We're trying to get these clients to the maintenance phase, and they shake, they become jittery, they can have seizures. Again, their blood pressure may increase, heart rate, and blood temperature also increase. Um, Lithium is a drug that's Librium, I'm sorry, is widely used for those clients with tremors and mild to moderate agitation. So again, we talked about the cognitive disturbance that you may see, and also the fetal alcohol syndrome that you may see. And these babies are usually born, they are shaking. And again, these clients also may go into what we call delirium tremors, DTs. acute alcohol or withdrawal. I'm sorry, alcohol withdrawal deliriums, also known as DTs. It's a medical emergency as well. Again, it can happen at any time within the first 72 hours. Remember, I told you that the client that came in, I think he was in an auto accident, he went to surgery, but he started going into DTs. They become very ill. They're critically ill. They have to, it's a medical emergency. These clients, they, like I said, the tachycardia, they diaphoretic, they have a fever, they're anxious, they can't sleep, hypertension. Like I said, they become very combative. They sometimes we have to restrain these clients to keep them from pulling out the tubes or falling, or we have to prevent them from injuring themselves. Okay, so again, prevention of alcohol withdrawal delirium is the goal. We want to make sure they don't go into withdrawals if we can. And sometimes if these clients are symptomatic, we may give them some diazepam, something to calm them down. To help with those symptoms. Like I said, that diazepam can help with the agitation, the tremors, and again, these clients hallucinate. Diazepoxide, it's the same thing as Librium. Again, it can help keep the clients out of danger. Sometimes more once the delirium becomes a pure IV Ativan or lorazepam is used to treat these clients with severe symptoms. So if they're very severe, they may have to get some IV diazepam. I'm sorry, lorazepam. The same thing as Ativan. So not diazepam, they get IV lorazepam. Is used to treat severe symptoms. Then I mentioned earlier, seclusion and restraints may be necessary. These clients, because they are diaphoretic, they start sweating so much, they may be at risk for dehydration. So we may have to give them forced fluids on them if they can tolerate it, or orally we do that, but if not, they may have to get it intravenously. So again, dehydration will be a big issue due to the diaphoresis. And then the elevation in the blood pressure, the heart rate, they're going to be at risk for um, cardiac dysrhythmia. So again, which all of these are medical emergencies. Systemic effects of alcohol, these clients can develop peripheral neuropathy, myopathy, alcoholic myopathy, cardiomyopathy, esophageal, esophagitis, I'm sorry, and then gastritis, pancreatitis, alcoholic hepatitis, cirrhosis of the liver, leukopenia, thrombocytopenia. Then again, of course, cancer. Um, uh, you may have heard the term esophageal varices. Those clients that drink a lot, they could develop esophageal varices. That's where the esophagus become very thin, and these clients die as a result of hypovolemia. They start bleeding. They just once those varices, those veins rupture, they start bleeding out, and usually they die because they bleed. Rapidly before they can get into a facility, before they can get to the emergency room, they die as a result of blood loss. Okay. Again, so like I said, cognitive disturbances, we need to be monitoring these clients. Again, they could definitely develop neuropathy, encephalopathy, I'm sorry, which is characterized by alteration in their gait, um, confusion, ocular problems, abnormalities as well. Sluggish pupils reaction, they unequal. They could also have blackout spells. And I kind of mentioned to you about the fetal alcohol syndrome. It can cause inhibit some intrauterine growth and then postnatal development. So these clients, like I said, when these babies are born, they usually kind of shaky, jittery. Um, Anthony is admitted to your psych unit from the ED. History reveals a dual diagnosis of both major depressive disorder and substance use. His history revealed he grew up in a home when early evidence of childhood depression was labeled as moodiness by foster parents. He was categorized as hard to place. He performed poorly in school because he could not concentrate and turn early. And in turn, he early developed drug. He resorted to drugs to escape from his hopelessness. hopelessness. So if you go back to the clinical picture and look at some of the risk factors, as you can see, Anthony demonstrates he falls in line with those risk factors. Okay, so this is how we tie, going back to our history, looking at anything that could contribute to the disorder. And again, it's based on this case study, it's evidence. He has all the risk factors for the most part. As far as our screening tools for these clients, substance abuse, there's what the screening, brief intervention, and referral form tool. Again, it's a brief tool that is used. I'm sorry, it's a comprehensive, integrated public health approach in delivering of early interventions and treatments to clients with substance abuse disorder. So again, initially, what the acronym means again, first of all, we're going to screen a nurse or healthcare professional in a setting can assess the severity of the substance use and then identify the appropriate level of treatment. So that's basically what that tool does. And then the brief interventions here, what we'll do here, the nurse or the healthcare provider focus on, increasing that client awareness and replacing those behaviors or negative or behaviors, and we try to motivate these clients change their behavior. So the goal here is for brief interventions to change the behavior of the client, to assist the client. Then of course referring to treatment, it's again it's the healthcare provider and the nurse responsibility to know those resources and get those clients into the right access. It may be specialty areas, it may be inpatient or outpatient, just depending on how severe the clients are. Then you have the audit. It's an alcohol use disorder identification test. Then you have the CAGE. It's a questionnaire that can be used to ask those clients a question. Then the CAGE aid form. It's the same question as the CAGE, but it adds drugs to drug use to alcohol. And so again, and then you have what we call the TACE. I'm sorry. It's Tolerance Anonymous Cut Down Eye Opener Tool. So these were tools were the audit tool again. These are all tools that have been very effective to use today and to help these clients to administer the appropriate care and get these clients in the appropriate treatment um, facilities. Okay. The nursing process, I'm not going to go in that in detail because of course we know we got to assess. Not only are we going to assess the client, we're going to be assessing the family. Okay, identifying the problem, setting the goals, determining the event that will be that the client that we help these clients accomplish their goals. Then you're going to look at your nursing diagnosis, look what outcome, what goals are you trying to reach for your client. Then once we do the assessment, we're going to implement some interventions. Again, we want to make sure that these clients are safe, that they're getting the amount of sleep that they need. And then the first line intervention is whether it's going to be, it may be medication or it may be counseling or therapy. So again, depending on your data that you collect, what would be most beneficial for the client. Then again, these clients, like I said, they usually have poor nutritional habits, and then they become dehydrated because they don't eat and drink the way they should. So again, if they are, like I said, if they're diaphoretic, because and sometimes you see alcoholics, they just sweat all the time, and that you they walk around, they just sweat. That's one indicator. Now we can't label anybody, but that's one indicator that someone may be an alcoholic. So again, they're sweating. So again, they losing fluids again, so they're at risk for dehydration. Then self-care. Sometimes they have poor hygiene. They don't take care of themselves. So we want to make these clients, explore things that are harmful to them, and then help them to identify effective coping mechanisms. Of course, healthcare teaching, promotion, prevention is going to be the key. And then there are a lot of public classes out there. You have AA, Anonymous, uh, AN, Narcotic Anonymous. There are a lot of support groups out there that we can link the clients to. Um, then again, we're gonna evaluate did we meet our goals, and if not, we know we got to revise. Make sure these goals are measurable for this client. Now, you're not a client that's an alcoholic. You're not gonna say the client would drink decrease alcohol intake from 8 drinks a day to zero. That's not non-realistic. So you want to titrate it down because they're not going to be able to do that. That's not realistic for that client. Okay. As far as treatment, uh, the dicephoram is a drug that's used for the clients going through withdrawal, and so you may also see the term antabuse. Um, they going through withdrawal. If they take this medication, it makes them so sick. They get nauseated, they throw up, they vomit. So again, if they have to take the medication. So if they stop taking the medication, or if they take the medication while they're drinking, like I said, they get really, really, really sick. And then of course the naloxone, the Narcan, and then we talked about the benzodiazepine. Motivational interviewing for these clients would be very informative. We wanted to try to motivate these clients as much as we can. So we're going through the process here, using your tools. But again, of course, we have to attend to their physiological needs first as we go through therapy before we get them into group therapy. So we have to make sure we take care of their physiological needs. Okay. Okay. Let me just go back, and I kind of clicked over a little bit too fast, but as we go through the stages, or change. We talked about the motivational interview, and I clicked that slide a little bit too early, but going back to that previous slide, and it won't let me go back. Motivational interviews, like I said, it's an approach based on theoretical or theories going through change. Now it's a good process. Um, Again, but we can't expect a client to go from drinking 8 drinks a day to 0 drinks a day. So we go through that phase. Sometimes it's approach to strengthen these clients to help them get through the chain. So again, we meet with these clients one on one. We counsel these clients, and they go through the stage. So now they may go to the first stage, they may contemplate, okay, pre-contemplation. Then they need assistance to get them to in that state. They need help because they thinking about getting help. They thinking about it. So they need that motivation to get them to that next phase. Then if they have acknowledged, they first of all they gotta acknowledge that they have a problem. And then they contemplate that they may not be ready for addressing that problem. So pre-contemplation, you need support to motivate them through all of these stages. Then they contemplate. They still not sure. And then, but the goal here is to get these clients. You want to get them in assistance. Get it. Want to prepare them, getting them ready. We're going to take action with these clients. We want to change them. Change needs to take place. One change is to get them in early treatment. Okay, and once we get them in treatment, then we want to maintain. We want to prevent them from relapsing. So if we don't get that behavior change, they're gonna likely relapse. Okay, they're gonna likely go relapse. I'm sorry. These are some continuum for substance abuse. Like I said, detox, rehabilitation. They're halfway houses, partial hospitalization, and I talked about the intensive outpatient programs. That methadone clinic is one. Our other outpatient AA, and then you also have alcohol, narcotic anonymous programs, and then relapse prevention. We trying to get these clients from going back into that to the initial stage. Okay. So again, there are a lot of support groups out there. So we need to know these groups so we can refer our clients. Anthony is getting ready to be discharged because he's currently homeless. His caseworkers find him a place in a men's shelter where he continues to search for halfway houses for continued recovery and support. For the substance abuse treatment plan to be successful, what factors should be considered? Now, again, we put him in a house with other men who we got to make sure that this house that we putting them back in is not a house where people drink. So you putting them back in the same environment, so you're going to get the same results for the most part. So this ends the lecture for chapter 22, substance abuse and addictive disorders. So again, if you would just take time to listen to the slides and look at the slides, and we'll be ready to further discuss.